by Dr. Chinnappa. So he'll be talking about the decentered IO, decentered IOL and the tilt. What do you do, Dr. Chinnappa?
Good evening, everybody. I thank Dr. Kurlu for having me on his team for this course. Now we saw this mind-blowing talk by Dr. Rohit Shetty about what happens on the surface that makes the patient unhappy after the surgery. Now we go into the eye and try to deal with some problems that happen on the IOL level, which we fail to identify at times. Decentration means there is a defect in the XY axis of the IOL, and tilt means there is some movement on the Z axis of the IOL. So most of the times, even after having uneventful cataract surgery, which when the patient comes back, you have a 6 by 6, and still the patient is not unhappy about the quality of vision. We usually tend to dwell a lot about the surface of the cornea rather than going and looking if there is some problem with the IOL itself, because you haven't had any problem with the surgery. It was uneventful. It looks pristine, and but there could be times when there would be small decentrations and small tilts, which could actually be the cause for the unhappiness or the blurry vision the patient has. So up to 0.2 to 1.8% of patients after cataract surgery can have IOL tilt. So with the present advancement in instrumentation and techniques, I'm sure it's more towards the 0.2% than the 1.8%. But still, there are cases where we encounter decentrations and tilts. So intraoperatively, the most important cause for decentration, which we could avoid, is a very large rhexis. So having a rhexis overlap of about 1.1 mm all round circumferentially on the IOL, it has been stressed upon, but we all try to achieve it, but we can't fool ourselves, because it is not absolutely a repeatable thing. There could be times wherein even after we try our best, there could be a rhexis which is not overlapping the IOL, and this could cause a decentration in the postoperative period. Zonular weakness, anything more than one quadrant, could cause a decentration. Haptics being broken or kinked. Yes, you inject the IOL and the trailing haptic gets caught in the injector. Which you somehow fight with the IOL, get it out, and you don't have the heart to actually explant the IOL and put in a new one. At this point of time, what we do is we tend to do kind of a cover up, and we think and hope and pray that the IOL won't be decentered. Even if it is decentered, we don't want it to be causing harm to the patient or symptoms to the patient, but sometimes it could. So it could happen intraoperatively or 1 or 2 days or few days after the surgery, but usually we don't see the patient few days after the surgery. Even if the patient calls you and says, the patient, I don't have very good vision, you over the phone, you would want to comfort the patient and say, we'll wait for a few days, it could get better. But if you would have left visco in the bag in a toric IOL, it could have caused a rotation of the toric IOL. And if there is a distension of the bag, it could have caused a tilt of the IOL, that is an anterior-posterior tilt, because as less as 5 degrees of tilt can cause some amount of blurring. So, and then there could be secondary causes, which could be patient-based, which can happen way later than the few weeks or days that I was describing. Like I said, a millimeter of decentration can also cause symptoms, especially in aspheric IOLs. So aspheric IOLs, the dictum is you need to have the apex of the cornea in center to the center of the lens. If that axis is moved even by a millimeter, it can cause some amount of symptoms. So in a spherical IOL, it doesn't happen as it's not as bad as in an aspheric IOL. And then I mentioned any degree of tilt in the z-axis, an anterior posterior tilt can cause an unhappy patient later. So effect of pupil size, yes. So not all patients have the same pupil size. Anything a patient with a 2 mm pupil size, you could get away with no symptoms. But anything beyond 3.5 mm, especially in a mesopic condition, patient will say, I was sitting in a restaurant or sitting in a movie. When I go sit in a movie, the things are not very clear, but I'm out in the sun, I'm up and about. So that is something that you need to assess and see whether the cause is on the lens. So you can actually grade the lens decentration by mild, moderate, subluxated, and dislocated, but it doesn't matter because the management of the decentered IOL doesn't really depend on that. So what symptoms could the decentered IOL cause? A decreased visual acuity. If it is a toric, definitely. If it is rotated, it could cause decreased visual acuity and induced astigmatism. Glare. If the edge of the IOL is at the or within the edge of the pupil, then that can cause glare and monocular diplopia. If there is a clear zone between the edge of the pupil and the pupil edge of the pupil and the edge of the lens. Floater like symptoms, yes. If you had a PCR and if you've convinced yourself you've done a good job, but still there is some amount of vitreous incarceration at the edge of the IOL, that could cause floater like symptoms. And if it is completely completely luxated into the vitreous cavity, of course, then that's a whole different ball game altogether. So there are multiple methods which we can use to actually measure. Purkinje imaging technique is like, if you see the third Purkinje image, which is blurry, that means there is some amount of decentration. So you can use the Purkinje imaging system over your slit lamp itself, but it is almost void because you have much better techniques to actually do this. You have a skin flow imaging techniques. These give you almost uh, a perfect assessment whether it is a decentration or a tilt that is causing an unhappy patient, or if the IOL is pristinely placed within the bag exactly how you want it to be. So this, I mean, some of the latest equipments could actually give you a measurement by itself, and now you don't need to do it manually. Here, and basically what you're trying to see is, if you're assuming that the anterior surface of the iris as the horizontal axis, and with that as a standard, you see whether the IOL anterior surface of the IOL is exactly parallel to it. If there is anything beyond 5 degrees, like I mentioned, that means there is a tilt of the IOL, and that should be addressed. How it should be addressed, I will come there soon. ASOCT, yes, again a great tool to actually measure tilts. Here you can see that the IOL actually has tilted about almost about 250 almost about 150 microns, which is a huge tilt. Here you can actually visualize that the IOL, one haptic is probably in the sulcus and the other in the bag. But the problem with ASOCT is that if the pupil is non-dilating, you can't actually whatever is behind the pupil. So eye trace aberrometry, yes. I mean, I don't think I should talk anything about the cornea here, because Dr. Shetty has already spoken in detail about it. Basically, eye trace, what it does is it separates the aberration that comes from the cornea and the internal aberrations. That's why it's so important, because once if you do a topography and see that the cornea is absolutely okay, still, like, you see that the patient is unhappy with glare and halos or starbursts, then you might have to see whether the IOL is the one that is causing the aberrations. And here you can see the higher order aberrations can actually directly be measured and seen that, like, here you can see that the coma and the trefoil are extremely high in this case, although the surgery was picture perfect. So and, like, if you ask me what do we do about this, I mean, not much, because, like, we couldn't really find a cause as to how, I mean, exactly what's the reason. It could be a manufacturing defect of the IOL, for all you know. So IOL dislocation management, yes. I mean, IOL dislocation is when there is a very gross decentration or a tilt, or if a part of the IOL is in the vitreous or in the anterior chamber. So that could definitely cause way bigger problems than a 6x6 patient. So, I mean, that's not really a topic that we need to touch on here. So when do you actually correct the decentration? If you diagnose the decentration, is at least about 2 weeks after the first surgery. Anytime after 2 weeks after the first surgery. So if you think that the bag sublux is the cause, then you put in a CTR and hope it could be corrected. But the problem with these techniques is, like, there is no absolute guarantee that you can give to the patient about the outcome of the second procedure. So you also have to, like, I mean, Dr. Sharath will be talking about macular function and the other things, but you always have to keep in mind that when you as a lens surgeon, you have to have a multidisciplinary approach when we try and tackle patients with who are unhappy even after a 6 by 6. So IOL repositioning usually done if one of the haptic is in the bag, or if the damaged haptic is the one that is causing the decentration, you could position the IOL, or you could remove and exchange it with another IOL. So anterior vitrectomy, yes, like in cases wherein you place the IOL in the sulcus, but there could be a small wick which is actually causing the decentration, then you do an do a vitrectomy to reposition it back into place. So IOL exchange, yes, IOL exchange is most commonly required when you've seen or you've been overconfident about or over enthusiastic about not changing the IOL on table even after detecting a haptic cut. In such patients, you always have to keep in mind a lot of other things, surgical nuances. And in some patients, what happens is, if the patient absolutely disagrees to go for an IOL exchange, a pupilloplasty could also be an option. So that could actually, could be a less invasive option. We have done it in 1 or 2 cases, and patients are relatively better after the surgery. Thank you very much.
Thank you, Dr. Chinnappa. I think the take-home message, if suppose patient is already having the tilt and or decentration, so can we do it immediately or can we do it later on? Because see, we have to, certain study shows that some amount of patient glare and hair loss, we give time for neural adaptation also. Certain patient just get adjusted with that, because always second surgery is always second surgery when you do that. So can we able to give them the option for neural adaptation, or straight away go it after a couple of weeks of surgery?
Absolutely, best case scenario is not to take the patient up for a second surgery, like you said. But like Dr. Shetty was saying about quality of life. Now when people talk about quality of life, and if something is bothering them, it is like a thorn under your nail. They keep coming back to you. You might rather take the radical decision of going in and operating than keeping it there and expecting, that same patient, same unhappy face sitting outside your waiting room. It's not a very comfortable sight to have those patients keep coming back to you.
One big challenge which all of us are going to face is when there is a transition from, say, the plano lenses, aspheric lenses, now the EDOF.
Yeah.
See, EDOF is heavily based on how your spherical aberration coordinates to your cornea, and how it balances or how it adds up. A small change in your tilt or the way the lens is positioned is going to be very, very less forgiving than what it used to happen in the past. So your talk today really emphasized the importance of it, but it's going to be maybe a millionfold important with the new lenses.
Yeah, but then I think we are kind of using EDOFs a bit more aggressively than we should, because not all patients are taken up for spherical aberration profile before taking up an EDOF. We are assuming that the spherical aberration profile is okay, and then advise EDOF for everybody. But then there are certain patients who come back and say that you promised us about intermediate vision, but our distance itself is compromised. That is because there is a conflict between the spherical aberration on the cornea and what you're giving on the lens.
Yeah, thank you, Dr. Chinnappa. In fact, pre-op evaluation is very